All right, we're gonna get started tonight. Thanks again for you guys showing up. If you guys are new to the lecture series, we're gonna go over a little review of last week's lecture with some questions, and then Jeff's gonna give us a lecture tonight on advanced imaging and orthopedic surgery. A couple weeks ago, we did one on more basic x-rays, and he's gonna get into some more different types of imaging modalities and certain types of x-rays for specific injuries. If you guys have any questions, you can feel free to type them in the chat, and I'll be keeping an eye on that. And yeah, we'll go through them, your questions as we go or at the end. So we'll start off with a review. So last week was adolescent idiopathic scoliosis. So our first question here, we launch the poll, is it more common in males, females, or equal? Alrighty. Majority of you guys, or 100% of you guys got this right. It's more common in females. All right, question number 2. If the curve progresses, it may do what? Alrighty. So again, you guys, majority of you guys got it right. So it's if it progresses too far enough curve, it's going to start pressing on the lungs, not give you enough lung volume, and you can start to have some respiratory compromise. Question number 3 is what Risser stage is this pelvis? So you look at the iliac wing apophysis, and then it's broken up into quarters for each group. And this will give us an approximation of how skeletally mature the patient is. Alrighty. So about 50-50 split here, and it's a B. So if you guys remember, like I said, it's 0 to 5. 0 is when there's nothing, you know. And then the rest of it, 1 through 4, is broken up into quarters. So 1 is about 0 to 25%. 2 is up to 50%. 3 is about 75%. 4 is 100%, and then 5 is completely fused. So if we look at this, it's about up to the 50% mark. So that's why it's a 2. Question 4. So this patient presents with the curves of measuring one of them 55 degrees. What do you want to do for this patient? All right. So the answer is posterior spinal fusion. It has a 55% curve, or degree curve. And so if you remember, anything less than 25, we can observe, and we'll get radiographs of either yearly, or if they're closer to that 25 degrees, we might get it every 6 months. Once they get past that 25-degree curve, anywhere from 25 to 45, and still a skeletally immature patient, then you can do bracing. And if they're past 45 degrees, then you want to do posterior spinal fusion. So if the patient falls in that 25 to 45 and you choose to brace, what's the minimum amount of time that needs to be worn to prevent any progression of the scoliosis? So it's 12 hours is the minimum amount of time. 16 hours is a little bit more beneficial, but a lot of the times you can just have the patients wear at nighttime and when they're at home. So you can do 12 hours and that's can prevent it from progressing. And then our fun question, this was obviously a question that Jason Chan prepared. So how many hours a day do pandas spend eating or foraging? No, sorry, I just realized I messed up putting the poll questions in. Jeff, you have any idea? Or do you already know the answer?
I saw the answer when I was putting it in the PowerPoint, unfortunately.
All right. So most of you guys think it's 10 to 16, and that's correct. So apparently a giant panda's digestive system is more similar to a carnivore than a herbivore. So much of what it's eaten is passed as waste. So they must consume 20 to 40 pounds of bamboo each day. And to obtain this, they have to just continue to eat the majority of the day. Alrighty. Here, I'm going to end it and sharing.
Okay.
See where to go?
Yeah, I just have a million screens open right now.
So if you click the share screen, it should come up to the PowerPoint.
Oh, I have to go to my system. Hold on.
See it?
Yeah, no, I just have to give Zoom permission. Oh, I have to log out and log back in?
Here, hold on.
Or it's from my computer.
Can you do it now?
No, I think it's like an Apple issue.
Okay. I can just continue and if you want, and I just can click through it.
Wait, that might have worked. Let's see. Oh no, it's working. You guys seeing it now?
Yep.
Okay. So what we're talking about today is we're going over imaging in orthopedic surgery. Again, the objectives are to go over the primary imaging modalities that we typically use in orthopedic surgery. We also want to understand when to use each type of image, and then also go into a brief introduction of reading the advanced imaging. In terms of reading imaging and what we're going to go over, we're going to focus on more of our sports medicine topics, so really shoulder and knee, in terms of X-ray, CT, and MRI. So the outline for tonight's talk is, again, going over the imaging modalities, what each one can give you, followed by going over some shoulder imaging and knee imaging, followed by a summary and then review questions. So looking at conventional radiographs, these are what we normally think of as our first line screening tool. It uses an X-ray machine, which you can see at the top of the screen, followed by a sensor at the bottom. And the X-rays are emitted, pass through the body, and are picked up by a photographic film or a digital cassette underneath. The films can be done primarily in the radiology department, where you will have this type of bed set up so patients can be placed in certain positions and moved around. The table moves around easily to X-ray different parts of the body, or you can use portable machines such as this one, where you have to place this individual cassette beneath the patient. But this does help in that it's similar to some of the newer radiology suites and departments. It is digital, where you do see the result of the image immediately, as compared to some of the older digital cassettes that require reading separate from where the patient is. Additionally, you can also sometimes see some more interesting pediatric type radiology tools. Unfortunately, we don't have these in any of our hospitals, but I thought that was a pretty funny thing to set up. When you're looking at conventional radiographs, you really need to remember that you need to look at both. You need at least two views in order to truly understand any pathology that's going on. Typically, these are orthogonal views, where one will be an AT, the other will be a lateral. When you're looking at the image, you note that it is the denser materials that you see, such as the bone, calcifications, any metal, will appear as a brighter white, whereas less dense materials appear as a darker gray. And anything that the radiology or the X-rays can transit through without any type of refraction, such as air, will be the dark black. Additionally, in some of these studies, whether it's looking at specific joints, you may require additional oblique views for a complete evaluation. Typically, we'll see that in the hand and the ankle to look at the mortise view. Again, things that we discussed back when we were doing the initial trauma X-ray reading. Additional, in terms of conventional radiographs, there are also stress views that can be done. This occurs where the examiner actually does a diagnostic maneuver while the X-rays are being taken. The image here, again, is showing a external rotation stress view to test the competency of the deltoid ligament to see essentially whether this is a unstable or stable fracture pattern. Additionally, you'll see stress exams, particularly looking at the knee, whether it's a trauma situation with a flat toe, where you want to evaluate for MCL or LCL instability, as well as stress views in the operating room by looking at a pelvic ring to see if it's stable or unstable. Additional tests that can be done with plain radiographs is you can also do an arthrogram. These can be done in pediatrics or adults. Here you see an image of an arthrogram of a shoulder where dye is injected directly into the joint. If the rotator cuff, since you see the dye going all about the shoulder, it's indicative of a rotator cuff tear because the dye is free to travel between the intra-articular and subacromial space. This type of test is helpful in patients, or has largely become essentially obsolete unless patients are unable to get MRIs, where this will help you delineate some more soft tissue pathology that you wouldn't see on a plain X-ray or a CT. Additionally, we know that we can use fluoroscopy with video in the OR. Again, this is where you'll typically do your stress exams in the operating room with the patient asleep. It's also important to note by looking at the image in the top right that the colors and the densities are inverted for fluoroscopic images as compared to our conventional radiographs. Again, here you'll see that air is the most bright, whereas the denser structures such as the bone, specifically the cortical bone, is showing up darker. We're moving on to the next modality, looking at computed tomography. Basically, this is a series of X-rays that are done in the axial plane. The machine itself spins around to get a complete image, cross-sectional image of the area in question. As the machine rotates and collects all the images, the axial cuts are used to reformat to make the sagittal and coronal cuts. Similar to X-ray, the tissues absorb the X-ray beam at the specific intensity as related to the density of the tissue. So bone is white, cortical bone is the whitest, air is the darkest, and then soft tissue is somewhere between. Again, this gives you a 3D image in the sense that you have axial, coronal, and sagittal images that you're able to piece together. Additionally, we have been using more three-dimensional imaging, essentially construction of CT scans in order to generate 3D images that you can use to help put together or evaluate a fracture pattern, or something like a tibial plateau, a pelvis, a pilon, something that's a more complex fracture pattern that even with a CT scan, it's hard to appreciate the larger pieces or smaller pieces in continuity.
Jeff, just want to point out one other thing. So most of the time we're getting CT scans for things that are more complicated, like Jeff said, or intra-articular, but you can also get, most of orthopedics is focused on the bones, but a lot of times we also get CT scans with contrast to look for abscesses and stuff. So that will be, you can switch it to a soft tissue window and better evaluate the soft tissue and see if there's any abscess or cellulitis or other thing involved in that, which CT will help you for.
Exactly. And again, that kind of goes back into the fact that CTs typically are easier to get in many institutions as compared to MRIs, such that if you're looking for evaluation of a abscess or fluid collection, you can give a patient contrast and have a CT done fairly quickly, whereas an MRI, which would also show you soft tissue and fluid collections, would take longer and is generally more expensive in most institutions. So again, the other option in terms of, I guess, our more basic but still advanced imaging modalities is the MRI. What it does is that the machine and the tube itself generates a static magnetic field to which radio waves are pulsed into the area being imaged. By creating a static magnetic field around the soft tissue, whether it's the leg, the shoulder, anywhere in the body, it aligns the polarity within the molecule, particularly with the water molecules within the cells. And by essentially using the radio wave pulse, it will knock the polarity off synchronously, but then each tissue has a different resonation that is picked up by the detectors. This again is correlated to the water content, and it is picked up by the sensors that are built into the machine. Generally, we think of MRI as being more useful for soft tissues, whether it's tendons, ligaments, cartilage, nerves. And again, similar to what Jeremy said, is that you do have options for contrast to be used in MRIs. Additionally, an MRI can also be paired with a arthrogram as well to help delineate intra-articular lesions, particularly if you think about a shoulder or a hip with a labral tear. That's somewhere where you'd see an intra-articular contrast injection. When we're talking about MRI on the most basic level, we really have three main different sequences that we're looking at to help delineate what's going on. The first one is the T1 weighted sequence. This helps us tell most of our normal anatomy, and that the fat is bright but dark. The darker areas are more the fluid, the cortex, tendon, ligaments, fibrocartilage. Here you can see, again, bone itself is showing up as bright white with the cortex being dark. We have our tendons with our patella and quadriceps tendon showing up as dark as well. And then you also see your ligaments within the knee that are showing up dark. Again, it's hard to tell the the difference between fluid or some of these other fatty fatty areas, so it's hard to differentiate areas of edema. So that's where T1 really lacks in terms of showing us the pathology associated with the image. Looking at our T2 weighted image, the bright signal is generally fluid. Again, a helpful mnemonic or helpful memory tool for this is that it's H2O is showing up as bright, so the 2 for water and the 2 for T2 show that fluid and bone marrow show up as bright, whereas the tissue, bone, ligament, muscles all show up darker. Here on this image, again, it's dark because most of the things except for the water aren't really showing up, but you can see the intra-articular synovial fluid. You can see an outline of the meniscus anteriorly and posteriorly, as well as your fat pad and the synovial fluid up top. And then there's also a third imaging. It's called the STIR sequence. It's short for short T1 inversion recovery. This is similar to a T2, but there's also fat suppression that is involved. Again, this is something that's more used in terms of looking at oncologic image issues, being able to classify different tumors and their consistency, which is something we'll get into a little bit later in a separate lecture about orthopedic oncologic imaging. So moving on, we'll talk a little bit about shoulder imaging itself. When you're talking about the x-rays, it's important to note that there really are 2 AP images that you can get of a shoulder. This is related to the natural anteversion of the glenohumeral joint. You can see in the illustration of each of these pictures, you're taking an AP of the shoulder. You're looking directly at the patient's lying flat on the table. It gives you a rough idea of the overall joint, whether there's degenerative changes, whether something looks grossly out of place, but you're not able to assess the concentricity of the glenohumeral joint itself. In order to do that, you have to do a true shoulder AP, which is also known as a Grashy view. This will help you look directly down the glenohumeral joint, as you can see here. And this is the actual space of the glenohumeral joint. This can be done by angling the beam and placing the cassette directly behind the patient on an angle. Again, keeping the plate and the x-ray beam orthogonal to each other, but again, using that angulation to help see down the joint itself. Additionally, with the shoulder, we can get images of an AP, whether it's a Grashy or a true or a shoulder AP, with the arm in different positions. This helps us look at essentially the different aspects of the shoulder of the proximal humerus as it's rotating within the shoulder joint. You can note the red and the blue dots on each image show you that the shoulder itself has rotated, and this can help you see some pathology that you may miss on one single shot of the shoulder. And then finally, we also like to get something called an axillary view in order to essentially rule out an anterior posterior dislocation of the glenohumeral joint. This shows you that the humeral head itself is articulating with the glenoid that's going off the scapula. Additionally on this, a big buzzword, a big thing to look out for is the lighthouse of the shoulder, which is the coracoid, and that is the bony structure that's anterior. That will tell you that this is our anterior and this is our posterior portion of the shoulder. When you have patients that have shoulder pathology, particularly the ones that you need the axillary image, whether you're concerned there may be a dislocation, they may have issues getting the shoulder out to this abducted position. There's another image called the Velpeau axillary, as you can see here on the right, where the patient leans backward over the cassette, and rather than shooting the beam up through the armpit, you're using the beam is going from superior to inferior through the shoulder, but still will give you an axillary view to allow you to assess for the glenohumeral reduction. So going quickly back to our imaging, looking at a shoulder AP, you can see patients that have gross changes to the shoulder, such as degenerative joint disease. Again, there's extensive osteophytes seen here. The shoulder is, the humerus is translated superiorly as related to the glenoid itself. Again, it's easy to be tricked that you could be thinking about a graft because you do see this thin line to say the joint space is narrowed, but the glenoid is actually this line here, which means that you're not truly able to assess the glenohumeral space itself on this image. That's where a Grashy view comes in, because again, you can see that the outline of the glenoid is much more narrow. We're seeing it more on FOSS, and you see degenerative changes, particularly this inferior osteophyte that's associated with degenerative joint disease of the shoulder. When you're looking at a shoulder itself, again, the internal and external rotation views help you see any image or issues that are either on the anterior or posterior aspect of the shoulder or of the humerus. Again, if you think about a internal rotation is going to bring anything that is posterior in the shoulder out laterally, so you'll be able to see a posterior Hill-Sachs lesion, whereas an external rotation will bring the anterior structures of the shoulder out laterally, where you can see the reverse Hill-Sachs. We'll get into what a Hill-Sachs lesion is a little bit later. Is that your question, Jeremy?
Yeah, that's my question.
So the reason we're going to hold off is this next image, the axillary, is actually going to show us exactly what a Hill-Sachs lesion is. Hill-Sachs occurs as a defect in the humeral head on the posterior aspect following a glenohumeral dislocation. The Hill-Sachs lesion itself is defined strictly as the posterior structure as related to an anterior dislocation. Again, you want to check to find the coracoid. Note that the humerus has gone out anteriorly, and as the soft tissue and muscles around the shoulder contract to try to prevent the humerus from moving further, the humeral head is impacted on the anterior aspect of the glenoid. That causes this lesion, and it's also something that's very important to remember when you're actually trying to reduce the shoulder, in that particularly patients with multiple dislocations, they're going to have this lesion that you have to unhinge in order to get the shoulder back in the joint. Similarly, you can have reverse Hill-Sachs lesions, where that would be the defect in the anterior aspect of the shoulder as the humerus goes out posteriorly and returns back to the glenoid. So that's something to look out for, particularly if you have patients with multidirectional instability. If there's a defect, it decreases the overall articulation of the humerus, something that may need a procedure to help restore stability to the shoulder.
Hey, Jeff, can you just go back a couple slides to the DJD? And you mentioned how the humerus is high riding. Can you also explain another reason why it would be high riding and what you can?
Yeah, I mean, so this goes back to what actually is probably the most common cause of degenerative joint disease of the shoulder, is that when you have a rotator cuff tear, what we call rotator cuff arthropathy, again, it's the pathologic process of a degenerative and torn rotator cuff. There's no longer the joint reactive couple and dynamic stabilizers of the shoulder to help keep the humerus reduced within the glenoid. As the supraspinatus and infraspinatus, which are the most commonly torn tendons in the shoulder, as they're no longer to help restore that concentricity, the humerus is going to start translating superiorly from the pull of the deltoid and causes the humerus to translate further superior. Again, when you think about that, you're going to lose the normal articulation of the shoulder itself, which will start causing edge loading, causing degeneration of the shoulder. You'll start to see these, again, inferior osteophytes, which are a hallmark of rotator cuff arthropathy as leading to arthritis. But that's something to really keep an eye out for, is if you have a patient that you see the humerus starting to slowly ride up, there's likely no longer tissue in the subacromial space, the rotator cuff. And that's something else that you have to consider when you're talking about treatment options down the road for this patient with arthritis. Okay. So CT scan imaging of the shoulder. Outside of trauma, there are, I'd say, relatively few reasons for shoulder imaging. In the past couple of years, there have been templating programs for total shoulder replacements, reverse total shoulders that have come out using CT imaging. to help determine where your placement of your replacement of the implant will be. It will help tell you if you have arthritis that is wearing out the back, the posterior aspect of the glenoid. You may need some bone augments. But overall, shoulder CT is generally used for the traumatic patient to see whether their proximal humerus fracture is operative or non-operative based on displacement of the fragments. Again, you can still roughly make out many of the muscles on the CT, but as we talked about earlier, the MRI is much more reliable for looking at the integrity of the rotator cuff, the intra-articular structures, and the muscles surrounding the shoulder. So next, moving on to the MRI of the shoulder. I know this is a busy slide, but I wanted to bring it up, particularly to bring up the citation, the MRI Master. This is actually a website I came across while I was putting this presentation together, but it's a pretty interesting website where it presents the coronal image in terms of this MRI, but you can scan through as you would on a normal MRI, anterior to posterior in the coronal image, and it still continues to label each structure that you see in the slide. It's really helpful in terms of tracking where tendons, muscles, bones are going. And again, it is overwhelming, but I find it easiest to really just make sure you orient yourself in the image. Again, remember that this is the coronal image, so we're looking essentially anterior to posterior at the a frontal view looking at the shoulder. And then you can also identify the bony structures. So again, we have the humerus out laterally, articulating with the glenoid. We see our clavicle coming across, articulating with the acromion. And once you, again, remember that this is a coronal image, you can start to see the supraspinatus and infraspinatus that are passing anteriorly. You'll be able to notice the deltoid out laterally. You'll be able to see the inferior labrum and superior labrum. And depending on the cut, you may see the biceps tendon coming across from the superior labrum down to the groove. Additionally, you have your some other muscles that you can see, your trapezius up top. You can also, again, see arteries and nerves on a MRI as soft tissue. And then you can also see the subscapular muscle that's attaching to the anterior aspect of the scapula, again, going to attach to the anterior part of the humerus. The other important view another important view looking at our shoulder MRI is the axial view. Again, this is looking from the top down, slices of the shoulder. And again, just orient yourself with the bone. Again, you have the humerus laterally, the glenoid medially. Anteriorly, you'll note that you have the biceps tendon, the long head of the biceps that traverses in the bicipital groove, which is between the lesser and the greater tubercles. These are important because that's where your rotator cuff muscles insert. Again, the lesser tubercle is your subscap, and greater tubercle is your greater tubercle or greater tuberosity is your superior and supraspinatus and infraspinatus attachment site. Again, you can see other muscles of the posterior cuff, your teres minor. You can see your glenoid rim, the posterior glenoid and anterior glenoid. And you can also see your suprascapular nerve and artery traversing down posteriorly. Looking at some images of pathology associated with the shoulder, as you can see on MRI, you can see on this image that there's a rotator cuff tear, as the tendon itself that you see coming in superiorly on this coronal image does not actually reach the greater tuberosity, indicating that there's a tear there too. Additionally, this looks like it is a contrast image where they injected dye, and the dye itself has leaked out down towards the glenoid, as well as up into the subacromial space.
Jeff, I'm going to stop you right there because there's a question similar to that, but they asked, can you use contrast in CTs, like a CT arthrogram? But most of the time it's more for this, the MR arthrograms, because you can see more pathology if you're looking for either cuff tear, or if you're looking at labral pathology, you can inject your dye in there and see if it exacerbates from the cuff or the capsule.
Correct. Yeah, I mean, the whole purpose of injecting the dye is to evaluate the intra-articular structures. And again, if we're choosing to look at the labrum, which is a soft tissue structure, an MRI is preferable as compared to a CT. You can also see on our next image, this is another coronal image looking at a slap tear, which is slap stands for superior labrum anterior and posterior. So it's a tear of the labrum that's attached to the superior aspect of the glenoid. Again, the labrum also continues circumferentially around the glenoid. So it's a tear of the superior aspect that extends anteriorly and posteriorly on the glenoid. This is the attachment as well for the long head of the biceps tendon. So in terms of treating this type of tear, you'll see it really depends on the age of the patient. Younger patients will have this repaired to help restore normal shoulder biomechanics, whereas older individuals where it's not as important, the patient will either have a tenodesis or a tenotomy of the long head of the biceps tendon, where by releasing the biceps from this insertion on the soft tissue, you're no longer pulling the glenoid, the labrum away from the glenoid as well. And you can also, in the same time, remove any pain generators that could be from the long head of the biceps within the bicipital groove. And then here's another image, particularly showing why it's helpful to use the intra-articular injection arthrography for an MRI. Again, this is showing us an anterior labral tear. These occur commonly in patients that have multiple dislocations of the shoulder. Sometimes it's just the labrum that is torn off anteriorly. Sometimes it takes a piece of the bone with it, which we term a bony Bankart lesion, whereas just the labral soft tissue injury is a Bankart injury. And again, by injecting the dye within the joint, you see that the dye itself is passing in between the labrum and the bone here, indicating the tear as well as traversing around anteriorly. Okay, so moving on to some knee imaging. The knee x-rays are much more straightforward than the shoulder. We really have the two main views, looking at an anterior and a lateral. When you're evaluating patients for arthritis, again, we think about arthritis as being possibly in 3 compartments. There's also a sunrise view, but our main initial screening imaging for x-rays for knees really is just the AP and the lateral. When you're looking at your AP itself, you want to make sure that you also identify the patella. You'll usually only see a faint outline because it's obviously overlying the femur. You note that the fibula is a lateral structure. You can identify any joint space narrowing, particularly if you have the x-rays taken with the patient standing. And you can also generally see different avulsion fractures that are associated with some ligamentous injuries about the knee. Additionally, on the lateral, you again want to evaluate the patella. You'll evaluate the overall alignment of the knee joint itself. Again, you can also look at the soft tissues in terms of the patella tendon, quad tendon, as well as any particular effusion that you could see elevating the suprapatellar fat pad. A couple different pathognomonic fractures that are good to keep an eye out for. The first one is the Sagan fracture. This is associated with ACL injuries, where it's a avulsion of the anterolateral capsule that results in a small avulsion fracture as the tibia itself rotates posteriorly. The lateral plateau rotates posteriorly, causing this avulsion fracture anteriorly. Additionally, you have a reverse Sagan fracture, again, where the Sagan fracture is lateral structure. This is a medial structure that is associated with a PCL tear. Again, as the tibia translates posteriorly, causing the tear in the PCL, you have an avulsion fracture of the capsule anteromedially that can be seen as this type of fracture. Another one we have is called the Pellegrini Steata sign. This is a chronic injury to the MCL, essentially where the medial collateral ligament of the knee is torn off, causing an avulsion. Soft tissue forms underneath the fracture, preventing it from healing, which shows up as this chronic ossicle that's actually your MCL footprint that is avulsed off the bone. Again, this takes a while to form, to stay out there. So it's more indicative of a chronic MCL tear as opposed to something more acute. And finally, you'll hear us talking about patella alta and baja. This is essentially where we're either saying the patella is high riding or low riding, dependent on what is going on within the knee joint. Patella alta, as you can see here on the left, is where the patella is pulled proximally by the quadriceps tendon, typically due to a tear in the patella tendon. So there's no longer a tether between the inferior pole of the patella and the tubercle. So there's an unopposed force from the quadriceps that bring the patella higher. Additionally, you'll see that there's patella baja, where the distance between the patella and the tibial tubercle is much smaller than it should be. This is generally related to arthrofibrosis, where the entire knee joint is scarred down. Or it could be related sometimes to a quadriceps tendon tear. The reason we don't always see a patella baja with a quadriceps tendon tear is that although the patella is intact, there's no contractile fibers on this inferior to the patella to pull it down below. Conversely, where a patella tear will be pulled north by the quadriceps the pull of the quadriceps tendon. Looking at our CT of the knee, again, similar to the shoulder, it is definitely more helpful for traumatic injury about the knee, the articular injuries, whether it's a tibial plateau or a distal femur fracture. Even some complex patella fractures warrant a CT of the knee. Again, we'll use the standard axial, coronal, and sagittal imaging. And again, it can be used with intravenous contrast to help identify any soft tissue or fluid collection or an abscess that could be causing a problem. More importantly, looking at the knee on the MRI, again, you want to look for the bone to help orient yourself. This is a sagittal of the knee, where you're looking from the lateral aspect towards the medial aspect. Again, we'll have a series of 3 images that will help orient you as we're going. But again, keep in mind the femur is superior, tibia is inferior, fibula sits a little posterior to the tibia on the lateral x-ray, and then we have our patella. Again, keep in mind that we have the dark cortices showing up. You can see the articular surface. So this is a T1 image. And then you can start to evaluate some of the intra-articular structures. We have our lateral meniscus posteriorly and anteriorly. Remembering that the meniscus is a semicircular structure, both on the medial and lateral aspect of the knee. You can also assess the quadriceps tendon and patellar tendon. And then you also have some fatty structures within the knee too. As you get to the middle aspect of the knee, again, keep in mind, keep orienting yourself with the femur and the tibia. Again, we're more medial, so we don't have the fibula in view anymore. But you can start to see these vertical strands of the ACL. As you move a little bit more more medially, you'll start to see fibers of the PCL coming in posteriorly that take a little bit more of a roundabout course from the femur to the tibia, as opposed to these straight vertical fibers that you'll see in the ACL. As you get closer to the middle, you can still find the roots of the medial lateral meniscus, which would be the insertion point posteriorly for the meniscus that can also be injured and would need to be addressed surgically if there's a tear at that point. As you make your way medially, again, at this point, we're medially past the patella, so that's no longer in view. We're seeing the femur proximally and the tibia posteriorly. You note the medial meniscus has the anterior horn and the posterior horn. And again, you're evaluating for any tear or disruption in the meniscus. One of the key notes that you guys may be asked is that in order to define a meniscal tear, it's not simply enough to see a disruption of the meniscus on one cut. You actually need to see disruption of the meniscus on 3 consecutive images in order to truly call something a meniscus tear on a image or on a MRI study. The other view that we really look at in terms of the knee is the coronal image. Again, orient yourself with the tibia and the femur. Keep in mind that when you're trying to evaluate the medial versus lateral aspect of the knee, you can use the anterior cruciate ligament that attaches laterally on the femur to the medial aspect of the intercondylar groove, and the PCL starts out medially and goes laterally. You also want to evaluate the medial collateral ligament as it comes down, connecting the femur to the tibia, as well as the lateral collateral ligament and structures such as the IT band that come down laterally. Some pathology that, again, we'll note, looking at a sagittal image of a knee, you see that there's disruption of the normal triangular shape of the medial meniscus. Again, you really need to see this on a couple different images in order to really define it as a true tear, but it's something that can definitely be a pain generator and be a cause for a patient to have either a repair or a meniscectomy. Sometimes you get something that's called a double PCL sign, which is actually where you have a flipped meniscal tear. Here on the image, you can see that you have your normal PCL that traverses posteriorly on the femur down to the back of the tibia, but you see there's an additional second dark wave that looks almost, again, like a second PCL. What that is actually the semicircle of the meniscus detached peripherally from the joint capsule itself and flips up into the intercondylar notch. That's really where you have space within the knee. This is something that you really have to get to pretty quickly if you're trying to fix it. Again, this does happen in young individuals. And some patients that you'd be really concerned about having a flipped meniscus get locked and ultimately just have to take the meniscus out of a 18 or 19-year-old really would be rough on their knee in terms of removing a primary stabilizer and a cushion within the knee itself. And then finally, in terms of our pathology, you can see that we do have, looking at an ACL tear, where the fibers itself start to become more horizontal as opposed to that straight vertical images that we were seeing earlier, indicative of an ACL tear. Additionally, when you have an ACL tear, you have this characteristic bone bruising, remembering that the ACL is a resist translation of the tibia anteriorly as related to the femur. So as the tibia is translated forward during the injury, the ACL is disrupted, allowing the tibia to go forward. And as it's returning back into its normal position, you have injury between the anterior middle third of the distal femur and posterior third of the tibia. This is a characteristic bone bruise pattern of an ACL. And it's generally something that they even talk about being a sign that if you're concerned that an ACL tear may be partial, that if you do see this imaging as well, it's a sign that their tendon, the ligament, ACL has to be completely torn in order for the bone to get in that configuration. So generally a quick summary. We know that conventional radiographs, generally a quick, cheap and excellent screening tool, can be also used in a diagnostic setting, such as stress fusion and arthrography. CT scans are helpful to identify bony pathology in detail. And then MRIs are generally best at examining soft tissue pathology. So before we get on to the rest of our questions, anything else, Jeremy, pop up in the chat or things we want to talk about?
Nothing in the chat as of now.
Okay, we'll do some questions, then we'll see if anything else comes up. Jeremy, do you have the poll, or do you want to?
I can pull it up if you just,
Do you need to take over?
oh, actually, I made you the host. Can you make me the host again? No. No, you didn't have to do that, but. Nobody saw that.
Okay, so question 1, identify the injured structure. Is that the supraspinatus tendon, the labrum, the biceps tendon, or the subscapularis tendon? Okay, yep. So we're looking at the supraspinatus tendon. This is an example showing you, again, the progression of the rotator cuff arthropathy, where the tendon that you'd expect to see as a dark black structure attaching to the greater tuberosity is no longer there. You do see some wispy structures as well as the supraspinatus over here superiorly. Oh yeah, sorry, you can't see my image. And then you can also point, Jeremy, just to the where the labrum would be on this image. The biceps tendon is not something you generally would see or be able to evaluate on a coronal image, similarly with the subscapularis. Okay, similarly, identify the injured structure in this knee. Is it the lateral meniscus, anterior cruciate ligament, posterior cruciate ligament, or the lateral collateral ligament?
You're looking at a coronal view. This is the lateral side. This is the fibular head.
Okay, so common answer there is the anterior cruciate ligament. What we're looking at here, again, actually is the coronal view of that flipped bucket handle meniscal tear. Generally, you would expect to see the meniscus, as you can see medially, would expect to see it laterally, but instead we have an empty white space beneath the lateral femoral condyle. That's where the meniscus typically is, but now it's actually flipped up into the intracondylar notch. In order to see the ACL, again, remember it's anterior cruciate ligament, you'd want to be a little bit further anterior on the knee. Again, we're seeing strictly the posterior aspect of the medial lateral condyle, distal femoral condyles. So you can see some of the PCL coming down from the medial condyle as it progresses to the posterior tibia, but you need to be further anterior to see the anterior cruciate ligament.
Yeah, but that is a good, for what tricked most people is, that was a good reference that this is the lateral condyle, and so the ACL should be coming in this kind of orientation. But as Jeff said, it's flipped up, so it was a tricky question.
And then finally, which of the following injuries is associated with an anterior glenohumeral dislocation? Posterior labral tear, a biceps tendon subluxation, a Hill-Sachs lesion, or a slap tear? Okay, good. Most of you guys got it. It's the Hill-Sachs lesion. If we go to the next slide, Jeremy, we have some images. Again, this is the same image as shown earlier of the anterior dislocation with the humerus translated anteriorly on the glenoid. You have this defect posteriorly in the humerus that you'll note on a CT scan. Again, that's the posterior defect. So it's also important to, when you're looking at this image, just to make sure that you don't get tricked into thinking that's the bicipital groove posteriorly, but that is actually a defect in the humeral head caused by a dislocation. And again, you can identify the coracoid anteriorly, even on the CT cut, in order to orient yourself. If you could just point that out, Jeremy.
Sorry, say it.
Just point out the coracoid on the CT scan.
Yeah, here.
Yeah, there you
go. Do you want to just go through what would you see in a posterior labral tear, and like what's a common type of injury or type of scenario that you would get that in?
Yeah, so posterior labral tear, generally in terms of board questions and what people are going to ask you, it's generally someone who has repetitive stress put on the posterior labrum. That's people who are athletes such as who frequently bench press, puts a lot of stress on the posterior aspect of the humerus or the glenoid, as well as someone like a football lineman. Additionally, you'll see posterior labral tears associated with posterior humeral dislocations, which are more rare than an anterior dislocation. But again, that can be with patients that are lifting weights that are football linemen and are subluxed posteriorly, or additionally, you'll see patients that are either have seizures or electrocution. Generally, are the typical patients you'll see a posterior dislocation. Conversely, with the anterior anteversion of the glenoid in relation to the shoulder, you'll more commonly see the humerus dislocate anteriorly or anterior inferiorly. There's a question in the chat about how you particularly reduce an anterior glenohumeral dislocation with a Hill-Sachs lesion. So again, the key thing really is trying to disengage that humerus itself. There are a couple different traction or different options in terms to actually reduce a shoulder, whether it's the traction counter traction method, where essentially you have a patient or someone helping you out, holding the body in place on the bed, allowing you to pull traction axially down the humeral shaft itself. If you have a Hill-Sachs lesion, you're not going to be able to strictly just pull it straight down. Generally, it requires either internal, external rotation to disengage that particular defect. So by rotating the shoulder, you generally can get to a smoother portion of the humerus in order to clear that lip. Additionally, there are other methods such as the Milch maneuver, where you slowly abduct the shoulder, do the position that Jeremy's doing right there, to get the arm up above the head, allowing you to disengage the humerus, disengage the Hill-Sachs, and reduce the shoulder. Generally something you're doing if you're doing it by yourself.
Yeah, for most of my shoulder dislocations, I just do counter traction, traction, and then kind of just internally and externally rotate the humerus, and that 95% of the time works for me. If you're by yourself, you can get creative and take a sheet and wrap it around the patient and then tie it to the opposite side of the patient away from you, to like the bed, and that gives you your counter traction. But if you're with someone, you can have the other person hold on the sheet and provide counter traction.
Yeah, Milch is nice by yourself, but it does take a while to get the patient's arm all the way up above their head, because obviously you can only go a little bit at a time because it is painful for the patient. Essentially, you have to get them comfortable and trusting you that it's going to take 10 to 15 minutes to get the hand up above the head, but generally it does go in.
And then, as Jeff mentioned before, after we get it reduced, we'll get an axillary view to confirm our reduction. And you have to just be careful that when you're abducting the arm to get your axillary view that you don't redislocate it. So you just have to be gentle with your manipulation of the arm.
Okay. Another question, how often do concerns about radiation exposure determine the imaging you get for evaluating patients? I mean, Jeremy, you can speak on this too. I think generally we will get the imaging that's required for the patient to have an accurate diagnosis. Really the only time that we'll consider radiation is if a patient is or concerned for pregnancy, particularly if we're talking about using a CT versus an MRI. I mean, I think more in the trauma setting,
and then also
you get what you need.
In pediatric patients too, we'll try to limit our radiographs, but if you need to get a CT scan to assess something further, we don't hesitate. Jeff, do you want to just also go over what you would see in a biceps tendon subluxation? I think you had an earlier slide that showed it a little bit better. I'm going to go back to
the axial shoulder.
Shoulder, yeah.
Okay, so looking at this image, again, keep in mind that the long head of the biceps travels up through the bicipital groove between the lesser tubercle and the greater tubercle. Again, you can see there's that black dot in between, right within the groove. Additionally, you have the subscap that attaches to the lesser tuberosity on the anterior aspect of the shoulder. Part of the soft tissue structure that is associated with the subscapularis tendon is also the covering of the sheath. So as the subscap tears medially, you actually see a unroofing of the sheath, allowing the biceps tendon to sublux medially outside the groove. In order to have a biceps tendon subluxation, you're going to have a subscapularis tear. So it's really something that's pathognomonic of a rotator cuff pathology in terms of the subscap if you have the biceps tendon sublux.
What was that the last one?
SLAP, which we did an image of earlier.
Alrighty, any other questions you guys have? I think next week we're going to be doing a lecture on oncology and imaging that you would get in imaging findings based on oncology. So same time again, 7 o'clock on Wednesday. Thanks again for joining us. And, you know, if you guys have any questions, feel free to email us or talk to us on the Instagram account.
Thanks, guys.
No problem.